Hi, everybody.
Wait,
It's Dr.
stand by,
Ricky
stand by.
Jones.
Stand by.
All right.
Go.
Hi, everybody. It's Dr. Ricky Jones from Louisville, Kentucky. Having some lovely technical moments, but I think we're here. I want to welcome everyone to my dogs, as well as this lecture. You would know that the flower delivery person would come at the exact moment we're starting. So if you'll give me about 3 seconds. And there you go. So I'm so happy to be with you guys today at the 7th International Early Age Onset Colorectal Symposium. I'm going to start off session 1, which is improving the earliest possible diagnosis and treatment and timely recognition of symptoms for sporadic young colorectal cancer. I want to recognize and thank Cindy Barassi and her team for putting this and allowing me to share our thoughts with you. After I give my presentation, we're going to have 4 other taped presentations. First from Lola Rahib, who's the Director of Scientific and Clinical Affairs at Cancer Commons. We're going to then have Lynn Lichtenfield talk about how to involve primary care in improving earliest stage diagnosis. And finally, we're going to have introduction of the Echo Chamber Challenge and Clinical Alert from Erin Peterson, who's the Director of Operations and Missions at the Colon Cancer Coalition. So let's get started. So here's my financial disclosures. And this is a problem we've talked about for years and years and years, and that's the delays between the time a person under age 50 with sporadic develops symptoms, and then this delay that goes on in the literature. And really, let's map it out here. So a person develops some symptoms, and often they're vague, they're intermittent. People don't really know exactly what they are, and many times it takes them a long time to be aware of those symptoms, as well as link them to colon cancer. And that's mainly a lack of information for folks. Then they make an appointment. And I heard last week a person who was told they had rectal bleeding, told the doctor's office, was put out 6 months for their appointment. So certainly there's a delay from that time the person knows about it and tries to where they get into the doctor's office and through the door. If they see their primary care physician, there may be additional delays before they're referred to a specialist for definitive diagnosis. So again, that's a long process. What we really want to talk about in this session is our goal of having people under the age of 50 and over the age of 50 be aware of symptoms and know their body, to know what the importance are, to quickly make appointments and get into that doctor's door early with 1 to 2 weeks, and so we can avoid it. And we can't change tumor diagnosis. I've seen people with 2 days of symptoms with metastatic disease. Likewise, I've seen people with symptoms for months, even years, who still have local regional disease. So we can't change tumor biology. But we do know that about 60% of early age onset colon cancers are sporadic, and that's established. We know about 4 in 10 are related to familial or genetic things, not necessarily genes, but a family history of colon cancer, advanced adenomas. So this is well established. And again, the symptoms are well described and well established. So none of these areas need to be studied any further. But what's not established is the overarching etiology. We've not found a definitive cause. There don't tend to be any signatures in our single nucleotide polymorphism profiles, our genetic scores, our risk scores. And we usually thought that inherited cancers made up between 5 and 10% of cancers, but there's been new data that comes out that may challenge that out of the Mayo Clinic. So is it 3 to 10%, or is it in fact 13 to 15%? And this study that just came out in JAMA Oncology studied all cancers, solid organ cancers in the Mayo Clinic, and subjected them all to genome testing, so germline testing, not the tumor characteristics of the cancer, but in fact the tumor characteristics that were inherited. And it was found that 1 in 8 people carry a predisposition to cancer. And in colon cancer, that's 15%. So 1 out of 7 people, essentially. There were high penetrance genes in 38%, moderate in 34%, and low in 16%. But what was the major predictor of a pathologic genomic variant? Early cancer diagnosis under the age of 50. And in addition, there was a very high rate of variables of unknown significance at 47%. That's usually 30% where we don't understand the nature of the mutation. We're not associating it yet with a cancer. And that rate was significantly higher in minority populations. And probably that's because we don't have good genetic information about minority populations. It's really based many times on Caucasians in America or those of European descent. So shift over. So that's what colon cancer is. We know about that. But let's talk about how early age onset colon cancer is related to people's overall colon cancer incidence. This was a simple rank order that I did where I looked at the incidence of colon cancer in a state and the mortality of colon cancer in a state per 100,000 and added those up to see who had the highest burden of colon cancer over here on the left. And then we used the ACS statistics about under age 50 colorectal cancer over here on the right column. And here are the top 10 states with the burden of colon cancer. And what do you know? 8 out of 10 of those were also in the top ranks for under age 50 colon cancer. And for the second 10 states, 7 out of 10 were in fact there. So 50 out of the top 20 states for overall colon cancer burden are also in the top states for under age 50 colon cancer. And so, you know, the hypothesis here is that our under age 50 colon cancer is driving to a significant extent our overall colorectal cancer incidence, particularly in high colon cancer states such as Kentucky, West Virginia, Mississippi, Alabama. And so I don't think states recognize this piece. And again, a lot of this is sporadic. And again, we don't know when people are 35 and they've not had an appropriate family history, when they first start having rectal bleeding, whether they are in fact sporadic or genetic. They're all going to present the same. But as we know, the faces of colorectal cancer are changing, so we must adapt our approach. And in fact, we need a complementary, not a competitive messaging strategy. You don't have colon cancer under 50 here and colon cancer over 50 over here. These need to be melded and brought together. And there's no greater example than Chad Bozeman here, who tragically died last year of colorectal cancer, died in his early 40s, developed it in his 30s. And I bet you he, unless he'd had a significant family history, hadn't received hardly any messages about colorectal cancer. Over here sharing the stage with him is Stan Lee, the creator of Marvel Comics. Well, Stan Lee probably heard about colon cancer 30 or 40 times. He's an elderly gentleman. We message strongly to people between 40 and 75. He had the right demographics. You know, you can't always get guys like Stan to get screened, but we've got to figure out better ways to get messages to guys like Mr. Bozeman, who are young in communities of color. I think he has a disparity in the fact that he's a man and he's not been in preventative health care all his life. Again, I'm just speculating. But these are the faces of the old messaging around colon cancer to where we need to go earlier to develop strategies around sporadic disease. And again, he's a Black gentleman, and here's all the different races and the different amounts of screening that they've gone through or compliance. And again, there's definitely differences. Hispanics and American Indians and Alaskan Natives suffering the worst disparities. But I would also suggest that there's a lot of commonality and a lot of screening going on. So yes, we need different messages to reach different populations. But again, what we're going to talk today is not a message based upon race or other identifying characteristics, rather identification based on the time frame at which you're delivering messages in order to educate people about the risks, what the symptoms are, when their risk profile determines what they should be screened with and when. And let's just talk again about this disparity. Women have a medical home, birth control, family planning, etc. They learn about breast cancer awareness very early in their life. They have a habit of preventative services with pap smears and everything. Let's just face it, they have a higher IQ. They're healthcare consumers. They are the family deciders. In every slide I've seen so far today, there's a significantly increased risk of colorectal cancer in advanced stage in people, in men versus women. So what about men? Well, men are dramatically less likely to have a primary care physician, especially in the 20 to 50 age group that we're so concerned about. Healthcare in young men is all about erectile dysfunction, hair loss, and it isn't until later that they worry about men's health issues around prostate, but they're not used to preventative health. Their interactions with physicians are through sports, cell, work, insurance. They maybe get a little bit in their college health space, but again, what about all the folks who don't go to college? And men are more reactive and less proactive. So there's tons of disparities out there, and we can focus on them, but we ought to focus on the greatest disparity, that we're not delivering appropriate evidence-based, guideline-driven information to people early enough for them to take an appropriate reaction. And here's the great news. We already have a lot of guidelines in place that will help us with the under age 50 colorectal cancer population. Here's an example of one of the tools that we use at the Colon Cancer Prevention Project. We can help you guys get this. This was in Spanish. We've got a couple of great ones for Appalachian and rural communities. But we have a lot of guidelines in place. And I'm not a believer that we create all these new issues if we're not following the guidelines that will help us in the under age 50 piece. And again, I'm going to use 45 like it's the new screening time, because we know that USPSTF is on the verge of announcing a final recommendation for 45. So, but number one, we never talk about primary prevention, diet, nutrition, smoking, alcohol. Rarely, if you're just getting the screening over 45, are you getting information about warning signs and symptoms that you need to be evaluated. Cancer family history for a decade, we've talked about it. It's a critical, you need to not only take it, but then apply it to guidelines to figure out who needs to be tested. And this is becoming so complex. I'm convinced it's eventually going to have to be automated. And then we're also going to have to benchmark this and reward for it if we want to get this done. We have talked this subject to death, and there's been minimal improvement, so we have to find a new way. In terms of people who are high risk that need to be screened at 40, people with family history of polyps or cancers. If we're talking to people at 45 or 50, we've already missed these guys' windows. And in fact, we know we screen only about 30% of the high risk people on time. So imagine screening the highest risk less than you screen the high risk. And again, 45 is coming, so we can all at least be glad for that shift up in the timeline. So this is a little slide about our messaging package. And what you can see over here is this great doctor, 45 to 75. And all of our effort is spent, and most of our resources is spent over here. We think the finish line for communication should be 45 or age 50, let's just say 45, not the starting point. And that's why we know we're breaking through in terms of cancers in people who should have been screened who are not being screened. So let's think about adding messaging. And again, messaging in the lead time allows you to deliver multiple messages in frequency that help to change people's behavior. And if you have a disparate issue, if you've got issues with socioeconomics and education, do you think you need more issues well in advance of the time you need to be screened, or less? Of course you need more. And again, knowing when your date is to be screened and what your options are. Average risk individuals have many options. You can't spring that on people. They need time to learn about it and decide. But this identifying symptoms, understanding your family history and the options and lifestyle modification are spoken about far too long. And this is about 35 to 50, which is in our cancer article with Dr. Shroy and Dr. Anand. But really, this needs to expand all the way back to people in their teens. Too many people don't understand that you can do primary prevention. Family history is critical, and identifying and evaluating symptoms is just part of where we need to refocus our message to help people with sporadic colorectal cancer get identified. So again, a different way. We've been spending tons of money and resources up here. And in fact, we need to shift some of those resources and information back into the early messaging package. And again, this is not competitive. This is how we reach the big, hairy, audacious goal of 80%, is with a big, hairy, audacious plan to involve people and go on offense against cancer rather than being on defense and being reactive. So in the last 10 years, we've spent a lot of time studying and researching. And I think as we started off, we know a lot about early age onset colon cancer, but we've yet to have big, huge actions. We've talked about it a ton. Aaron's going to talk about the echo chamber. I still think we're there. For us to really combat this and to make plans in our next 10 years, we don't need to study first and then act. We need to act on what we know right now, which is we need more awareness, more messaging. We need patients, hospitals, and healthcare providers to get on board and be aware. And we can simultaneously try to better understand the etiology, do dissemination and implementation research, understand the etiology, better use logistics and tech. But we don't need to wait on action until we have got the research puzzle completely figured out. So where do we want you guys to direct your efforts on informing people and providers? Don't wait. So first of all, at the national level, ACS and NCCRT are going to develop a new project to develop messaging guidance around reaching those under 50. So that's the fireworks here. And of course, we're all ready for USPSTF. The primary organizations, primary care, emergency medicine, GI, surgery, OBGYN in particular, because they have such a critical role with women, need to be engaged. And finally, urgent care corporations, emergency rooms, pharmacies, minute clinics. They see a lot of these people in their 20s to 50s who walk in and aren't really sure what's going on. They need to be brought up to snuff. But those are a lot of big national issues. Remember what you can do locally or regionally. You can discuss the onset. Do you know where your state ranks in under age 50 colon cancer? Talk to your consortium. Share that data. Your state medical and nurses associations are great sources to get information out. Public health and local health departments, Medicaid leadership, MCOs, those states that have had Medicaid expansion. Remember, it just became a core measure, colorectal cancer screening added to breast and cervical cancer screening. Get with your hospitals or hospital associations, cancer advocacy groups. Medical and nursing school curriculum should be talking about under age 50 colorectal cancer because of the reality of it, helping people understand those symptoms of sporadic colon cancer so they have a shorter piece. And then public-facing issues, use your ads to begin to talk to people at a younger age. Don't have just folks with gray hair like me on these ads. Have some folks who are younger in their 40s and 30s. And again, that's going to be 100% critical. And you don't need to wait for all the national organizations to put some work together in your own local community. So thank you very much. I'm going to stop my sharing, and then we're going to roll over and hear some great presentations, and we'll have about 20 to 25 minutes for Q&A at the end. So thank you guys so much, and back to you, Aaron.
We can't hear anything on the presentation.
Aaron, we can't hear any of this. Still can't hear any of it.
Hi, my name is Lola Rahib and I'm from Cancer Commons. I would like to thank the Colon Cancer Foundation and the organizers for organizing this meeting. The title of my talk today is Projections of Colorectal Cancer Incidences and Deaths. The American Cancer Society estimates that over 149,000 people will be diagnosed with colorectal cancer and over 50,000 people will die from colorectal cancer in 2021. Colorectal cancer is estimated to be the third leading cancer in both male and female, and the third leading cause of cancer-related deaths in both male and female. We have seen a significant decrease in colorectal cancer incidences and deaths over the last few decades, which can be attributed to screening. Here, as we see as the incidence rates are decreasing, we see an increase in the percent of people who are receiving colonoscopies. Although we have seen these decreases in colorectal cancer for the overall population, there has been an increase in both incidences and deaths of colorectal cancer in younger people. Over the last few decades, we have seen significant decrease in both incidences and deaths in people who are 65 and over, and also in people who are 50 to 64 years old. However, people who are under 50, there has been a pretty significant increase in incidence since about the year 2000. There's also been an increase in death rates since around that time as well. We recently published an article in Hi, my name is Lola Rahib and I'm from Cancer Commons. I would like to thank the Colon Cancer Foundation and the organizers for organizing this meeting. The title of my talk today is Projections of Colorectal Cancer Incidences and Deaths. The American Cancer Society estimates that over 149,000 people will be diagnosed with colorectal cancer and over 50,000 people will die from colorectal cancer in 2021. Colorectal cancer is estimated to be the third leading cancer in both male and female, and the third leading cause of cancer-related deaths in both male and female. We have seen a significant decrease in colorectal cancer incidences and deaths over the last few decades, which can be attributed to screening. Here, as we see as the incidence rates are decreasing, we see an increase in the percent of people who are receiving colonoscopies. Although we have seen these decreases in colorectal cancer for the overall population, there has been an increase in both incidences and deaths of colorectal cancer in younger people. Over the last few decades, we have seen significant decrease in both incidences and deaths in people who are 65 and over. However, people who are under 50, there has been a pretty significant increase in incidence since about the year 2000. There's also been an increase in death rates since around that time as well. We recently published an article in JAMA Network Open to look at projections of cancer incidences and deaths to the year 2040. The goal of the projections is to guide future research efforts, funding allocations, healthcare planning, and health policy efforts. We use population from the US Census and current population-based cancer incidence and death rates using the surveillance epidemiology and end result program to calculate the changes in incidence and deaths. We combined the most recent sex, age, race and origin, and cancer-specific delay-adjusted incidence rates from SEER with existing US Census projections by sex and race to calculate the estimated incidences by cancer type. Cancer-specific incidence and deaths in the US were estimated for the most common cancer types, the top 10 cancers. We then incorporated the average annual percent change in incidences to our estimates for all ages and for age group 20 to 49 to calculate the estimated cancer incidences to 2040. Hi, my name is Lola Rahib and I'm from Cancer Commons. I would like to thank the Colon Cancer Foundation and the organizers for organizing this meeting. The title of my talk today is Projections of Colorectal Cancer Incidences and Deaths. The American Cancer Society estimates that over 149,000 people will be diagnosed with colorectal cancer and over 50,000 people will die from colorectal cancer in 2021. Colorectal cancer is estimated to be the third leading cancer in both male and female, and the third leading cause of cancer-related deaths in both male and female. We have seen a significant decrease in colorectal cancer incidences and deaths over the last few decades, which can be attributed to screening.
Hi, so while we figure out technical things with the video, I'll jump in and do the presentation that was supposed to happen at the end of this grouping now, talking about the challenge of the echo chamber. I'm going to share my screen. This is the first time I'm trying this, so bear with me here. All right, so the challenge of the echo chamber. First of all, thank you everyone for being here. My name is Erin Peterson. I'm the Director of Mission and Partnerships for the Colon Cancer Coalition. I appreciate everyone being here, and I really thank Cindy Barassi with the Colon Cancer Foundation for inviting me to return to discuss this important topic again, and to Dr. Whitney Jones for being such a strong leader in the effort for individualized on-time screening. I do need to give a shout out for the echo chamber idea to Dr. Albert out of Chicago. He kind of really reinforced the idea of the echo chamber and what it means as we face the challenge in the rise of early onset colorectal cancer. So what is the echo chamber and who is in it? Well, it's us. We keep talking to each other about this problem. We meet at conferences, in summits, on social media, in events, in webinars, but we keep talking to each other. We aren't reaching the people who aren't in the echo chamber, those with average risk, the general public, the uninsured, asymptomatic or symptomatic patients, those with family history or unknown family history. We're also not reaching those other healthcare providers outside of our engaged healthcare that is in this space. Nurse practitioners, Dr. Jones mentioned OBGYN, the emergency department, pharmacy, urgent care, and others. The really low-hanging fruit we really talk about is this group, this age 45 to 49. We know that we're waiting for the USPSTF to lower the screening age, and if they do that as expected here shortly, we'll have the opportunity to reach up to 75% of young onset colorectal cancer patients with preventative screening. One patient we will hear from later in this presentation. So our challenge is to break out of this echo chamber. How do we put the discussions that we have had with each other into practice to impact future patients? We need to reach the uninformed and the unengaged in the general public, at-risk and average-risk individuals, as well as others in the healthcare field. How do we find ways to encourage young people to recognize what they are experiencing is not normal and to reach out for help and symptom evaluation? So how do we take the discussions from this weekend and other meetings like it and reach the public? How do we find those average risk populations and others outside of our echo chamber in the general public? I don't have a perfect answer. I do have some ideas, and we can discuss those as we go on as well in the question and answer series at the end. But we do want to make symptoms of colorectal cancer easier to talk about and less stigmatized. And as we make those conversations less scary, patients have told us they're afraid to talk to their doctor about symptoms because they're afraid of what they might find out. We know these symptoms can be signs of many other treatable and manageable conditions, but there is no reason for anyone to live with uncomfortable symptoms because of the fear of a diagnosis. So how do we make talking about colorectal cancer symptoms less stigmatized? And then as we start thinking about the 45 to 49-year-old age group and screening, how do we talk to them about their options, both with visual-based screenings like colonoscopy, sigmoidoscopy, CT colonography, etc., and also stool-based screenings? And do we focus this age group on stool-based screenings so that we can easily reach those 22 million Americans that will be eligible for screening when 45 is recommended by the USPSTF? So how do we reach younger adults, those who ignore their symptoms or have complaints that go unrecognized with their healthcare team? Some out-of-the-box ideas that have been put out there, and these are just a couple ideas from my organization, the Colon Cancer Coalition, as well as a campaign run by the Colon Cancer Foundation this past March, to really reach the uninformed and the unengaged in places where they wouldn't expect to see them, in the grocery aisle, on the street corner, or even on their beer can. And how do we go outside the echo chamber to reach our healthcare system? We know we need to take the discussion to the healthcare community, but doctors are busy and there's not enough time in an appointment to talk to all patients about all things, including the signs and symptoms of colorectal cancer. If we can engage them in a meeting like this, where they can learn about the problem. But my personal question for healthcare on the front lines as colorectal cancer is on the rise in young patients is how do we recommend the same evaluation for a 20 or 30 something that presents with symptoms as they would for the 50 to 60 something that has the same issues? How do we make that jump to get them to recognize that colorectal cancer is on the rise, the symptoms are the same, and they need to make the recommended screening for a colonoscopy when their 20s and 30s and 40s are presenting with blood in their stool, unexplained weight loss, anemia, and some of the other classic colorectal cancer symptoms. Dr. Tom Weber, who headed up the Colon Cancer Challenge Foundation, led the creation of a clinical alert in 2019, outlining this issue and the rise of early onset colorectal cancer. This document has been made available and has been shared, but it is still relevant and something that we can still continue to push out into the physician space, reaching healthcare providers, those that would see the young onset patients on the front lines, emergency room, primary care, OBGYNs, urgent care, pharmacists, et cetera, that list that Dr. Jones talked about earlier. The document, I want to highlight just a couple of key things as we go through it. One is the overview of the issue, including some of the statistics. Another is the list of the signs and symptoms, ending with a call for that evaluation. If these signs and symptoms are presented in a patient, how do we make sure that they get evaluated? And then also the importance of family history, including hereditary syndromes like Lynch syndrome, FAP, and the higher likelihood for an early onset diagnosis when a first-degree relative has polyps and advanced adenomas. And then finally, the action steps that can be taken to reduce the incidence and mortality for young adult colorectal cancer. As we think about what we can learn from this weekend, and as you take away information from today and the next 2 days, think about what questions do we need to be asked? Who needs to be at the table? How do we break out of this echo chamber so that we can continue to make an impact in young onset colorectal cancer diagnosis? We need to make sure we're talking to the communities we're trying to reach and that they're involved in part of the conversations and the planning as well. And that's me. If you want to find me, I look forward to question and answer when we're completed. And hopefully we can move forward with the video presentations and the technical issues are all filled out. Thank you so much.
Thank you, Erin. That was great. I know and want to thank everybody for their patience on our video work. It's a new platform, and I'm glad you all met my dogs in Louisville when the delivery truck came in there. So I think we've all had that experience over the thing. So Abby, how we looking?
I think we're ready to go, guys.
All right, super. Thank you so much for all the work behind the screens.
Give me one moment.
Yes, ma'am. So by the way, Erin, that was a great talk. I'd love to get those slides shared out too. I mean, that echo chamber is why you and I are trying to break out of it at this meeting.
Absolutely. Happy to share.
Hi, my name is Laura Rahib and I'm from Cancer Commons. I would like to thank the Colon Cancer Foundation and the organizers for organizing this meeting. The title of my talk today is Projections of Colorectal Cancer Incidences and Deaths. The American Cancer Society estimates that over 149,000 people will be diagnosed with colorectal cancer and over 50,000 people will die from colorectal cancer in 2021. Colorectal cancer is estimated to be the third leading cancer in both male and female, and the third leading cause of cancer-related deaths in both male and female. We have seen a significant decrease in colorectal cancer incidences and deaths over the last few decades, which can be attributed to screening. Here, as we see as the incidence rates are decreasing, we see an increase.
I apologize. I'm not sure why it's not working, but Whitney, why don't you take some live Q&A while we figure this out on the back end? Does that work?
Yeah, so we've been answering a couple of questions in the chat. One of the questions that came up was, do we know the impact of the microbiome on this, and if antibiotics had any changes? And there's a lot of people studying the microbiome, but we don't have any real data yet in terms of a definitive cause. We know that antibiotics affect the microbiome. One of the other issues is many of the cancers in people under the age of 50 are in the left side of the colon and the rectum. And for those of you, a little GI physiology, your stool comes out of your small intestine liquid and it gets concentrated as it progressively moves over towards your rectum and anus. So it certainly raises the possibility of a concentration gradient. And again, the microbiome can affect not only the microbiome environment, but also epigenetics and change how genes are expressed. So I think there's lots of research on this, but to date, there's no definitive association with antibiotics or unequivocal alterations in your microbiome. The second one I want to take is someone wanted to know about that clinical alert, which was great. One of the great things Tom Weber challenged us with. And I'm going to ask Cindy Barassi to either put it in the chat, and I just see her on the chat board. They're going to distribute the clinical alert to the group. So I'll be happy to take any other questions for myself or Aaron. Either unmute yourself, or if you want to put it in the chat box, we'll go from there. Any thoughts from any of the survivors out there or the warriors who are still in this, to any of the issues that Aaron and I brought up about the echo chamber and how we need to quit talking about it and start working on informing people? Does any of that hit home with you guys? Aaron, how about you guys? You work with a lot of survivors. Is that a common complaint about the medical profession?
It is, and I think the when we hear the complaint the most, it's when they consistently go to the doctor with symptoms and things get misdiagnosed or a delayed diagnosis because there's no way that they could have colorectal cancer even though they're too young. And we know that. We talk about it. We discuss it on a daily, sometimes hourly basis about the rise in young onset, and we need to figure out how to reach people that will actually be able to diagnose the patients at an earlier stage.
But like your slides, there's such a diffusion outside of that echo chamber. We talked about the various physicians, the various sites of care, the people who are seeing these young folks. They're not a primary care doctor like a 60-year-old might be where you have it. They're going to the Minute Clinic. They're going online to Google. They're at the university center. How do we better disseminate that information about A, the rising increase, and then B, these warning signs that in our practice, if you came in with rectal bleeding, you weren't ascribed with IBS and hemorrhoids until you had an evaluation. That was that was standard operating procedure, not it's probably IBS and it's probably hemorrhoids. We'll see you in 6 months. Try some fiber and some preparation H.
Right. That's the challenge, I think. And, hopefully we can do some outreach into the medical associations as well. And to get that out to their membership, the clinical alert that Tom put so much work into, we want to do a more concerted effort to disseminate that a little broader as well, just to really get that message out there about what the colorectal cancer symptoms, and they don't have to be, it doesn't have to be a scary diagnosis either. Most of the time those symptoms are something else, but they really should be evaluated for everything, and not to just, you're too young is probably isn't a diagnosis, isn't something you walk out the door with the information of, it is this and you need a evaluation.
Right. And a lot of the symptoms of colorectal cancer overlap with serious conditions like Crohn's disease or ulcerative colitis. And we got a question from Lizette Caesar, who asked, why is colon cancer so often misdiagnosed as diverticulitis? And what I would tell you is that diverticulosis is a very common condition. It affects many, many people, probably as many as half or more of folks after 50. And so it's less common in younger people. But again, it causes on a CAT scan, symptomatically, it causes abdominal pain, sometimes change in bowel habits. Some people get diarrhea when they have diverticulitis because of the inflammatory component. If you get a CAT scan, it shows up as an inflammatory mass. And many times that radiologist won't be thinking cancer. They'll be thinking, hey, this is probably just diverticulosis. They had pain and they've got an inflammation. Send them home on some antibiotics and follow them up with their doctor in a couple of months. So in our practice, anybody with severe diverticulosis and diverticulitis, if you think it might be diverticulitis, you don't want to do an endoscopy within the first month because of the potential for perforation or actually hurting that person. But you need to have that person followed up and to make sure there's not an associated cancer or tumor. Many people with young colon cancer get diagnosed as a result of a perforation, which very closely mimics a diverticular perforation. So that's a great question. Let's see what else we got here. Dr. Lynn, do you want to comment how you think we might be able to engage the primary care physicians? I know that's going to be part of your talk, but as part of our technical workaround, love to hear any of your thoughts.
Well, you've covered a good amount of my talk already, and frankly, if necessary, because of the technical problems, I'd be more than glad to give it. I don't have slides or anything, and really, it's much more of a conversation. But I think that's a very valid point. I have actually been both a primary care physician and a practicing oncologist at different points in my career. And I just, this is going to be repetitious. You'll hear this again during if we get to the slides or if I give the talk itself, which I'd be more than glad to do. But, you've already mentioned the issue about education and about outreach. And you mentioned about, primary care physicians, primary care clinicians. I think we have to be much broader in our approach because as our health system evolves, more and more primary care will be delivered by advanced practitioners and physician's assistants. So we have a broad landscape to cover. And frankly, there are many opportunities to engage in educational sessions. So the type of discussions we're having here today do fit very well into some of the continuing education conversations that are had routinely, whether it be large organizations or state-based organizations that may have scientifically oriented communities or state specialty organizations. So primary care, internal medicine, family practice, GYN was mentioned, and I don't think it's a conflict, but my wife is active in ACOG and she's a gynecologist. And women, they are a primary source of healthcare for women. One of the other problems, and you've alluded to this during your, Aaron, in your conversations, the pattern of care is changing. And so, younger people may not have, one of the things we've always talked about for years is the fact that the primary, being able to identify a primary source of healthcare, a person, identify somebody who's giving them preventive care is critically important to the success of any screening project, any screening program. But that's shifting, that's changing. And I'm not sure going forward that we're going to have those relationships. So, but here's the key point. Here's the key point. I think if we keep doing the same thing we've always done, and that is we keep going, and it's important, don't misunderstand me, for those of you who are medical professionals out there, we keep going to the professional community, we'll have the same results. It's going to be hard to change it, and that's because of the context in which they practice. Patient and consumer knowledge and awareness is critical to demanding evaluation of appropriate symptoms. People have to be their advocates. Now, not everyone's equipped to do that, but I do think that patient awareness and patient advocacy is going to be critical in the healthcare system going forward, and not just about colon cancer or colorectal cancer diagnosis, but many other things as well. So a long answer to a very fair question, we can get the educational piece on board. We can make that happen. These are important, just like we're having here today. Dr. Rahib's talk, for example, your talk, Whitney and Aaron. Those are valid talks for primary care education. That's an audience, but we also have to reach the consumers wherever they are.
Points, Ken. And I'm going to reach out to Aaron and find out, Aaron, if we're still working on the tech backstage, I think Dr. Lichtenfeld has his slides and he can go ahead and do his talk off of the, rather than the tech, just do a live piece, because I'd love to hear from him, because we're so much all reaching out to our primary care providers, including family physicians, to sort of help us out. And I think it can really give us some perspective and move the discussion along while we're working on the tech. Does that sound okay? All right.
I would say yes.
Yeah, I'm gonna take the chair's prerogative on this session. So, Lim, why don't you pull up your deck, and then
well,
I've done this enough to walk.
I don't have slides.
Okay, well then you go ahead.
So
and
it's a conversation, and so bear with me, everyone, because I have pulled it up here, and it is a conversation, and it's really an extension of what we've been talking about here before. So let me just share with the audience. I'm Len Lichtenfeld, and I'm formerly the Deputy Chief and Interim Chief Medical Officer for the American Cancer Society. I'm currently an independent consultant in Atlanta, Georgia, and I have no relevant conflicts to disclose. And I think this is an incredibly important topic. I mean, clearly, the issues, the data that came forward from our intramural research group, Becky Siegel and colleagues at the American Cancer Society several years ago, and it was really a shot across the bow that this is an important situation, important symptom, an important sign, important disease that we have to pay attention to. But I'm going to draw on my experience as a primary care physician to share with those of you in the audience, and not all of whom may be clinicians, some of the issues that are faced by primary care. And I think that sometimes we need to recognize that signs and symptoms of any disease are at times difficult to evaluate and difficult to pinpoint at any one moment of time. And although I said this, I have this later in my talk, maybe it's important to emphasize in the beginning, and I think the comment has already been alluded to. You may have something, a doctor, a nurse practitioner, a physician assistant may think it's a certain situation, but you don't just pat people on the back and say, see you later. You follow up and you have people come back and you make sure that the situation, how the situation evolves, because this is a potentially life-threatening circumstance. Red blood in the bright red blood in the stool from the primary care clinician side is actually not uncommon. It is a common symptom. And we have to remember that we don't even know, and based on the research that's been done, we suspect that symptom is in fact substantially greater in the general population and in the young population than we realize, because a lot of people don't even bother coming in. But this does not, that fact does not diminish the impact of colorectal cancer in young adults, but it does highlight the difficulties that are faced by both patients and physicians and clinicians as they try to evaluate a symptom. So one of the things that's also important, and a lot of people aren't even aware of this, we really need better information systems to tell us how common these situations are. We need to understand, but that's a whole other conversation for another time. COVID has highlighted our inability to understand data of medical care, and that again has been alluded to: quality oversight, how frequent a symptom may be, what we do about it, what the outcomes may be. We're still relying on pretty antiquated means to get answers to questions, and they're not always as accurate and as robust as we would like. It's already been alluded to, in fact, many of these points, so let me just touch on them briefly because I do think they're important. Many of the patients who end up being diagnosed with colorectal cancer, young adults who get diagnosed with colorectal cancer, have had symptoms for a period of time, and they've been seen frequently, sometimes by multiple physicians. That's what research shows. And so that's why it's so important for follow-up and awareness. We've already talked multiple times about awareness. And unfortunately, one of the realities that has to be part of this conversation is that bright red blood in the stool is actually not necessarily an early symptom. And Dr. Jones has already pointed out that sometimes people can present with symptoms that go on for months and they have very localized disease. Sometimes they have a very immediate evaluation, they have metastatic disease. I certainly saw that myself in my own practice. In fact, I saw a gentleman once who was young, as 39 years old. He presented with bright red blood in the stool. He presented with anemia, actually. He turned out to have a right-sided colon lesion that we scoped, we biopsied, we did scans at that point in time, the tests that we had available. And he had no evidence of metastatic disease, and we were going to take him to surgery, and the surgery was done 10 to 14 days later. And he had widely metastatic disease, including lesions in the liver that did not show up on the CT scan. So this is a disease that can behave viciously, or it may not progress so quickly, but that variability is critically important. Key, however, again, underlining, it's so important that we need to do a much better job. And that's already been alluded to several times. Better job of awareness and diagnosis, but we have to keep reality as part of that conversation. One of the interesting things that I found in reviewing for this discussion and just going back and checking, there aren't any really hard and firm guidelines. I've heard some comments, and Dr. Jones may wish to elaborate a bit on that. But for those of us who are docs, there's, and I don't want to mention any brand names, but there's certain tools that we use to tell us what's the right thing to do under a particular circumstance. I went back and checked what I suspect to be the most widely used tool when it comes to diagnosis of symptoms, and they make it very clear that this is a difficult diagnosis to make, that there's no uniform guideline of absolutely what people should do. So the wisdom of the clinician is important, the awareness of the clinician and the patient is important, and the follow-up by the patient is also important. And again, has already been alluded to, those young people who are, let's say, in the age of 45, 30, 20, whatever, and I've seen colon cancer in 20-year-olds as well, those young people do not have the same sense of follow-up and continuity for healthcare as do older folks. And I've got to tell you, as said already, that men in particular are so reluctant to go back. So you have that combination of a lack of primary contact, things that are a situation where they're not focused on that circumstance, and you get a mix of a situation that, in fact, becomes very difficult. So there's no easy answer. Let's emphasize something else that's so critically important, has been mentioned before. History and a family history is key to making the diagnosis. In fact, the history and family history are probably as important, except if you had a large rectal cancer. The history and family history are probably as important, if not more important, than what the actual exam is going to show you at the moment in the doctor's office, first presentation. Lynch syndrome has been discussed, inflammatory bowel disease has been discussed, and to be very frank, and Dr. Jones already mentioned, we do not do a credible job of taking family histories and acting on those histories in this country. We do not do it well. We didn't do it well when I started commenting on this back in the early 1970s, and we don't do it well today. In fact, we may even not do it less well than we did in the past. Their systems are available to automate the process. Family history is critically important. Taking a good history from a patient is critically important. Not just, I've got blood in my stool, let's do a rectal exam, see you in 6 months. That's not adequate medical care. So we discussed the importance of history. We're talking about the lack of primary care clinicians because everybody doesn't have the same system of care that some of us are fortunate to have. As I mentioned earlier, going forward, we're probably going to have a much more dispersed system of care. And if you start using urgent care or other types of clinics and drugstores, what have you, they can get that information and they do try to follow up. But the reality is, get some care here, get some care there, get some care somewhere else, see a clinician here, see a different clinician next week. Something gets lost in that process. And so that means that we as individuals, the consumer, the patient, have to be very much a part of this system. So what can we do? Again, and again. Awareness. consumer education. And not everybody is a patient. So consumer awareness campaigns are critically important. And don't laugh at me, but when you have a symptom or a sign of a medical problem, what do? You go to Google or another search engine and you Google it. And Google can immediately tell that what you're Googling. And I will tell you one circumstance, without getting into too much detail. I had a health-related issue, and I Googled it, and 2 minutes later there was an ad that was in my inbox, and you're all familiar with that. The algorithms are powerful, and perhaps even that type of system could be harnessed in order to say to people, if you're having a symptom, this is what you need to do. Let's put it in the context of public service. And although sometimes people may laugh at me when I say those things about algorithms and diagnosis and reminding people at the point of inquiry, maybe we ought to rethink that that's a legitimate way, particularly with a symptom like blood in the stool or abdominal fullness, bloating, pain, discomfort, whatever. We've already discussed medical organizations, particularly ACOG, the American College of Obstetricians and Gynecologists, physicians, American Academy of Family Physicians. Those are organizations that have national meetings, they have local meetings, they have state meetings, state medical societies sometimes have scientific meetings. Those are all organizations that would welcome highly qualified CME with information of the type that you've already seen here today. So the other piece is the need to constantly remind clinicians. Now, let's put something in context here, and that is we live in a world where a lot of information is coming at primary care clinicians. The burden, and I mean this sincerely from my heart, the burden on primary care is overwhelming, and the resources are exceptionally limited for them to do their job. So that's the fundamental foundation. And in order to be effective, we need to keep all of that in context. So in summary, colorectal cancer in young adults is a genuine and serious and increasing problem. We need to make clinicians aware. We need to make the young adults themselves aware. We have to recognize how it fits in the context of routine care. We have to realize the values of histories and family histories and physical examinations. And we also have to realize the value of follow-up and attention. When we do it, whether we do a colonoscopy, it is not possible to do a colonoscopy on every person who presents with rectal bleeding. That simply is not realistic. We do not have the workforce or the system in place to do it. It's hard enough. I just had my screening colonoscopy, and I'll tell you, it was hard enough for me to get an appointment. We have to at least be aware that there's some judgment involved, but it has to be in the context of all the things that I've already mentioned. I hope that one day we'll have a blood test, that we will be able to do a blood test for screening purposes, not for diagnostic, but for screening purposes, and that may help us out. Until then, you are going to be an incredibly important part of increasing the knowledge, increasing the awareness for all parties, everyone who's part of this process, to make sure that they know when they have a symptom like blood in their stool, or they have a pain or a discomfort, that they must see a clinician and they must get follow-up. And the follow-up should not be, oh, I see X, therefore don't worry about it. That's a common error. Follow-up means follow-up, and making sure that the symptoms continue, that they also have follow-up with their clinician, and may save a life. So with that, I appreciate the opportunity to speak with you today. I look forward to the questions and being part of the panel. I'm going to hand it back to our moderators for them to go on to the next presentation. Thank you.
Great. Thank you so much, Dr. Lichtenfeld. That was a great talk. And I think, unless you've been a clinician, you have no idea those burdens coming on. Electronic health records you thought would have made life better, but they've complicated it. And it's hard for patients to understand, this is doctors' missions, yet they're so distracted. Most physicians spend 3 hours at home completing medical records every night after they finish their 10-hour day. But to your point, I think that, I have a saying. I said, if we don't step up to the plate as clinicians and as health systems, Amazon eventually will. And, I think that we all use the internet for many things, and again, using it for positive is really critical. There are blood tests on the future, some that are going to be actually out in the market this year, but most of them are going to be slated for people over the age of 50, maybe for the use of diagnostics in people under the age of 50. That's yet to be determined. You want to make any comments on that? And then I want to go ahead and tee Dr. Rahib up. We're going to have you do an abbreviated version, or if you have slides, after Dr. Lichtenfeld answers a couple questions. So be on the ready.
Well, thanks, Whitney. The issue about blood tests for the early diagnosis of cancer, I mean, there are some blood tests that are already on the market. Unfortunately, they're late-stage diagnostic tests that are generally used in older adults who don't want to get colonoscopy. But we are heading into it. The science is heading into a new era, and the commercialization of that science. So, in very short order, we're going to have some blood tests that are going to be offered to people, and they're almost like a yes, no, you have cancer, don't have cancer. But as the science improves over time, we are going to be able to find cancer by looking at DNA, by looking at gene fragments in the blood. And the technology it'll get there. The progress made in the last couple of years has been substantial. So we'll be able to get to a point where older folks like myself, and you referred to, that's the gray hair thing, older folks will be able to get those blood tests. But I wouldn't be surprised at some point in time we're going to start moving down the age range to be able to use these blood tests to find cancer and other diseases. I had very quickly here, I had an interesting conversation a couple of years ago with a pediatrician, a very knowledgeable pediatrician researcher, who said that newborns were routinely going to get their genes sequenced. And of course, we talked here several times about inherited diseases. Imagine the difference that might make. So, over time, we're going to be going down the scale to those fewer and fewer cells will be able to detect that DNA. Of course, the parallel problem, I have to say, is that sometimes we're going to find things that may say, yes, this looks like it could be a cancer from X or Y, but it is a cancer that's really going to cause a problem. And a lot of that gets further and beyond where we want to be here today. But maybe another time we'll talk about that. I think it's going to happen now. But the science is going to improve substantially over the next 5 or 10 years. So stay tuned.
Right. And the American Cancer Society just finished a webinar series in conjunction with the Prevent Cancer Foundation talking about these tests. And they're called multi-cancer early detection tests. And they're based on blood samples that enough DNA leaks out from tumors into blood that you're able to detect it. And again, there's talking about them being done at an earlier stage versus late stage if it's done there. We're going to see more data and we'll see real world evidence when it comes out. But I think it's really exciting. I really wonder how the medical community is going to react when the dog catches the truck it's chasing, because we've wanted a holy grail of cancer early detection based on a simple blood test for years. What do you think? Do you think clinicians are going to be able to, you talked about their capacity to take in this fire hose of knowledge. Are we going to have data management and informatics tools to help doctors really use this technology?
So this has been a recurring issue in medicine for the past number of years, particularly as our information resources have expanded to such a substantial degree. We have all sorts of information. I mean, the viewers may understand that even things like my Fitbit watch generates tremendous amounts of data. So we're going to need systems to actually process the data and put in front of the clinician, not only in front of the clinician, put in front of the patient. Patients, again, coming back to that word, activated patients. People are going to take more responsibility for their healthcare. It's been a shift that's occurring over time. It's going to continue to occur for my children, my grandchildren, and their children. I mean, so we're going to have systems that are able to do that. This is not the first time it's happened. If you go back to the history, I like to cite the history of genomics. You've heard the 23andMe, and I went to meetings 10 years ago where people stood up and said, I got my whatever number of years, I got my 23andMe. And I'm going to go to my doctor and find out about all these things that showed. I don't mean to pick on 23andMe. There are a number of those services out there. I have all these things about my health and I don't understand. I got to tell you, at that time, my thought was the doctor doesn't understand it either. You have to pick what's real and needed and necessary. And you have to understand that not everything that shows up in a test means it's a bad outcome. There's not only the genes we have, but the environmental influences that go on that impact those genes, things that we don't yet understand. So be prepared. We're going to a data-centric world with all sorts of information about us and our bodies, and we're going to need systems because the primary clinician is not going to be able to teams of information. They cannot sit down and look at my Fitbit data for the last 3 months or last 6 months, along with my blood pressure, my weight, my pulse, my nighttime stuff. They can't look at all that and process it in a reasonable way. We need to have, again, augmented intelligence types of approaches that help us put dashboards in front of our clinicians and in front of us as consumers and patients to help us manage our own care, understand our own care, and understand our own bodies for that matter.
Yeah, I think that's well stated. I think everybody better get ready for the on-ramp to the fast lane of informatics and logistics and genomics in medicine, and particularly in cancer medicine, not just for diagnosis, but for surveillance, minimal residual disease. It's going to really wrap things up. So first of all, I want to encourage people in the audience to let's see some more questions from that chat box. I love Cindy Barassi, but I want to see some more of you guys. And I want to ask Lola if you're ready to sort of proceed, since we're in this tech challenge day. How are you looking, Lola, to give us the high points of your talk?
Can you hear me?
I can hear you.
Oh, yeah. Sorry. Yes. Yeah, sure. Yeah, sure. I can go through the talk.
Yeah, that's great. Well, if you would, go ahead. And I'm sorry, so sorry for the tech difficulties you had. But I mean, if you can go ahead and do your talk. And if you want to abbreviate it for the high points. And again, I encourage people in the audience to bring out some questions. We've had some great questions so far. Don't stop. One of the tests that Dr. Lichtenfield was talking about, somebody asked about an elevated CEA with a normal colonoscopy. Well, that's why we don't use CEA to screen for colon cancer, because it's very nonspecific, particularly worsened by smokers. So Dr. Rahib, if you're ready, we're going to turn it over to you.
Sure. So is the presentation going to play? Sorry.
Can you
Well,
turn your camera on, Dr. Rahib?
Oh, yeah, sure.
Well, I don't know if it's going to play. Do you have your slide deck with you? Or there you go. We can see you now.
Oh, great. Oh, so you want me to pull up the slide deck?
Yeah, I think you should just go ahead and do it the old-fashioned way. We were trying to get them all taped and clean, but it's been a techie kind of day, so we should roll with it.
Okay. Yeah, I'm sorry. Just give me half a second and I will pull those up.
All right, that's great. Yeah, so a lot of questions out there about the microbiome. Aaron or Dr. Lichtenfield, do you want to comment on about the cause of under age 50 colon cancer? Any comments from your guys' standpoint? I always tell people there's guys smarter than me working on it. I'm going to wait. I'm going to work on communication pathways to young people, so I'll be ready when they figure it out. But any thoughts from the ACS world?
Well, let me emphasize, I don't speak for the American Cancer Society anymore. But they were kind enough to have me on board for 19 and a half years. I think it's a great question, and you addressed it actually, I think, well earlier during your talk when you looked at that question about microbiome. There's obviously a substantial amount of interest in microbiome and its relationship to multiple diseases and multiple issues related to health. As far as early age onset colorectal cancer, we know, and we've talked before, you and I both, we talked about inflammatory bowel disease, we talked about family history, and you talk about sporadic cancer, and there's a lot we don't know. Overweight and obesity, once again, is a major issue. Our diets, our sedentary lifestyles, and those are fundamental factors that affect all types of cancer, or not all, but many types of cancer. And they probably have a role here too. And the question we used to always ask ourselves is, as you watch this obesity epidemic unfold across the country and younger adults, and the parallel that had with the incidence of early onset colorectal cancer, could that be an explanation? But the reality is there's so much we don't know, and that's the limit of my knowledge. I can't, and I'm always reluctant to speculate. But that's what research is all about. That's why we need to fund research. That's why we need to continue to contribute to research, and we need to support investigators who help us answer those questions. They're critically important. Microbiome is one piece of a very large puzzle.
Well, what a great segue to Dr. Rahib. Speaking of funding research, and I look like your slides are up, Lola. So are you ready to roll?
Yep, I am ready to roll.
Great.
I
And
guess-
thank you for your patience. So Dr. Rahib is going to talk to us about projections of colorectal cancer incidence and deaths and what the future looks like if we don't get off our butts and get more work done around this.
Sure. Okay, so you can see my screen and I'm advancing correctly. Is that right?
Can you put it
Yes.
in slideshow and then presentation mode?
I will do that.
That would be great. Perfect. Thank you.
Is this okay? Great. Okay, so thank you guys for inviting me to speak here today. So the ACS estimates that 149,000 cases of colorectal cancer will be diagnosed in the U.S. and over 52,000 deaths from colorectal cancer will occur in 2021. So this is for this year. And for male and female, colorectal cancer is third leading cause of cancer-related death and incidences, and we've all reviewed this before, so I'll move on. So we have seen, as I think someone else has discussed this before, we have seen a significant decrease in colorectal incidences and death in both males and females in the last few decades. And we think this is probably attributed to colonoscopy screening, where here we see the incident rates go down and the uptake of colonoscopy screening, it goes up. Let's see. So although we've seen a significant decrease in colorectal cancer overall, we see this decrease in 65 years and over and 50 to 65 years in both male and female and incidence and mortality. We see this increase in incidence and mortality for patients who are under 50. And this is kind of, the incidences have been kind of going on since, the year 2000. And same with mortality, actually. You can kind of see this increase around that time. So we recently published an article in JAMA Network Open to look at projections of cancer incidences and deaths to the year 2040. And the goal of the goal of this study was to project the cancer incidence deaths so that we can guide future research funding allocations, healthcare planning, and health policy efforts. So what we did is we combined the most recent data from the US Census and SEER, which is the surveillance epidemiology and results program that houses all the cancer statistics from various registries across the country. So we combined the most recent sex, age, race, and origin and cancer-specific delay-adjusted incidences from SEER and the U.S. Census. And the reason we wanted to look at the census is to look at population growth and minority and immigration changes as well, and also just the changing aging population. So we looked at these various factors and to estimate incidences by cancer type for all ages, and also for this 20 to 49 age group, which we wanted to specifically look at that, and also we looked at deaths in the same manner. And what we found is that let's see. So this is for all ages. So currently the most incident cancers in the US are breast, lung, colorectal, and prostate. And what we estimate is that by 2040, that breast, melanoma, lung, and colorectal will be the most incident cancers. And for cancer deaths, we projected that lung, pancreatic, liver, and colorectal will be the most the cancers with the most deaths in that year. So, and for the younger group, the 20 to 49-year-olds, what we saw is this increase. We see this very steady increase in colorectal cancer incidences, and by 2040, it will be the second leading cancer in this age group. And we also see a very modest continued increase in cancer-related deaths in this age group for colorectal cancer as well. And because breast cancer deaths are projected to decrease significantly, colorectal cancer is projected to be the #1 cancer-related deaths in this age group by about 2030. And, really quickly, these are just like the various numbers. We see the steady increase in incidences and certainly in deaths as well, but not as prominent. So conclusion, we see a decrease in colorectal cancer incidences and deaths for all ages. However, in the younger age group, we see a very substantial increase in incidences and also in death. And yeah, so by 2040, colorectal cancer will surpass thyroid cancer to become the second leading cancer, only second to breast. And by 2030, colorectal is projected to surpass breast cancer to become the leading cause of cancer deaths in this age group. However, this is something we don't want to happen. So our hope is that our projections don't come true, and that things will change. And our hope is that this study will bring awareness to the early onset colorectal cancer community, and there would be increase in research funding and development of screening programs, and of course, increase in advocacy so that we can get to that point. And that's it for me. Thank you very much. I hope I did that okay.
Lola, you did a great job. And actually, we're going to ask you to give your talk again because you've already taped it and given it. So we thought we'd just roll through the whole piece. So now that was a great talk. I have a question for you, though, to start off. Given that this is in the 20 to 49 age group and we're barely going to move the age down to 45, are we going to have to do more than think about average risk screening in 45 as we message the population?
Yeah, that's an interesting point. And one of the things I'd like to see is how the numbers look once because they put out these new guidelines for 45 and over. I'd like to see the 45 to 50 age group. I'd like to see what that would look like in a few years, and if that is what is mostly, contributing to this, or if it's going to get better. But as far as, our hope is to continue to advocate for, and I feel like if we need to continue to advocate for a, younger starting point for screening, then that's maybe what we need to do.
Okay, great. Aaron, any thoughts or comments about what this future looks like for us? And I think it's already the #1 cancer mortality for men. And then again, this change where breast cancer is going to be so dramatically impacted, is going to sort of leave colon cancer, as we say, without any pants when the tide goes out, right? So, well, it is, because it's pretty stable across that line, and really it becomes #1 by the lack of change versus breast cancer. What is breast cancer doing that we're not going to be doing? Are they just going to be better or smarter or better advocacy? What's it going to take?
Dr. Rahib, please stop sharing your screen.
Oh, I'm sorry.
Thank you.
So what do you think it's going to be that you have any thoughts around why breast cancer is going to fall so dramatically during that time, and colon cancer is leveling off so much, and we're not making change? What's the real projection and the science behind that?
Were you asking Aaron or were you asking me? Sorry.
I was asking you, Lola, or either of you can comment on it, but it's your data.
I thought you were asking Aaron. No, I think screening definitely is a big part of it for breast cancer, and also there's just been a tremendous advances in treatment as well for breast cancer, where unfortunately we just don't see that in colorectal cancer at the moment. I mean, we hope that changes, and I think it has to be both. It has to be, more screening and advancement in treatment, so that we can combine the two and see those numbers be reflected.
Aaron, any thoughts about that and what we can do to interrupt that curve? And I love the way Dr. Rahib said, we don't want to be right on this.
I hope she's not right as well. I think it's really interesting. I was really interested with Dr. Lichtenfeld's discussion about continuing to outreach to the general public and get the messaging out that way. The conversations, again, in the echo chamber that we continue to have are, how do we reach physicians? How do we reach physicians? We're doing, organizations like yours, Whitney, and mine. We continue to try to talk to the general public, and sometimes we do it really well and sometimes we don't. So hearing his conversation, Dr. Lichtenfeld's conversation about continuing to outreach to the general public and not just the physician base that will see patients, I think is a really good reminder to continue the work that we're doing for the advocacy side of things. But I think we are getting our marching orders through this conversation, and it's to continue to beat the drum and bang the pots and pans and blow the horn as much as we can and as loud as we possibly can.
No, that's great. And there's a question, Lola. Did you parse the data for 20 to 45-year-olds who won't be screened? Or in other words, what would it look like if no one did screening?
Yeah, so the data actually probably does not represent the 45-year-olds that received screening, because the guidelines were put in place after the data was collected. So and that's why I would like to see what the future data looks like, because we used the trends from 2016 because that's what was most available to us. So yeah, like in a few years, I would love to see what those numbers look like after there's this movement of getting more of the 45-year-olds and 20-year-olds screened.
Okay, great. There's a question that came in. Was there a panel of blood testing that can be given to 20-year-olds that consists of CBC, iron, total iron binding capacity, and vitamin D? In other words, screening for chronic blood loss?
If I can enter into the conversation here, I think we need to be a little bit cautious about saying that by lowering the age of screening, we're going to solve the problem. Right now, based on where we are today, I think that there's always a benefit and risk. And that when we talk about population recommendations, we have to remember we're talking about hundreds of millions of people. And creating a workforce to do that, or creating an opportunity to be able to afford it, you really have to balance the benefit and the risk. That's why education, awareness, with what we have today. As far as the blood test panel, same issues. I mean, when you go and do a CBC on a young woman, for example, the odds are much greater that you're going to find it related to other conditions rather than colorectal cancer. And vitamin D is off the table as far as the task force is concerned. That's not going to give us the answer. So I do think that we need to start paying a heck of a lot more attention to family history. And you mentioned that, Whitney, earlier on. I'm going to say it again and again and again and again. And you as an individual, whether you forget the clinicians doing it, You as an individual should know your family history. You should know what if you can. I can, unfortunately, but you should know what because the age differences were so great. What your grandparents died from, your aunts, your great aunts, what your cousins. That is really an incredible clue, and that's in our hands. That doesn't cost anything to find that out. And we all know who are on this call here today, on this discussion today, that understanding family history is one of the underappreciated factors in colorectal cancer diagnosis. And we need to do a better job across the board. And that's something that's within all of our power.
Yeah, I couldn't say it better. I mean, I've been, I think Tom Weber's the first guy that flipped my switch about family history many, many years ago, and I haven't stopped since. So, but I think it's going to have to be automated. I don't think that, because it's not just taking the family history, it's then applying it to guidelines, which are changing every month. So there's no way a busy frontline provider, much less a second line provider, can do their work and keep up with that. I mean, medical geneticists have a hard time keeping up with that. So I think it's going to have to be automated, and I think it's going to have to be integrated with the electronic health record in a way that works. And again, a couple of great things. And talking about going where people are, someone had a comment about one of the breweries lost one of their patrons who had colon cancer, and they made a special beer for them. So that's a great idea to take the message to where people are. And again, if you want to meet men, if you want to meet men, but if you're a man and you want to reach them, sorry there, Aaron, that wasn't, you got to go where they are. And so one of the questions is, why doesn't colon cancer do a better job like breast cancer of being everywhere? Sports, media, maybe colon needs to be in toiletries. Maybe it needs to be in loungewear, yoga pants.
I've got to share with the audience that idea is not so far-fetched. Within the Black community, for example, there have been initiatives within beauty salons and barbers to reach the community. That's a matter of reaching people where they are. I don't think it's going to happen necessarily in a pub or a bar, but it will happen through other targeted approaches like what you were just mentioning. So as far as the automation of the family history, we don't have time, but actually, believe it or not, I know somebody who developed a solution for that because a physician who was so concerned about his family and the family history and leading to the death of his relatives that he has an automated system, and then that automated system in turn says, this is what you need to be concerned about. If you want to take it one step further, wouldn't it be terrific, which it ain't going to happen because of privacy, if your family history changes, wouldn't it be great if it could communicate to your other family members' family histories on an electronic record? That's future think. It ain't going to happen now, but that's where we should be. We should be able to direct and help people get the care they need and the awareness they need, because nothing has more resonance than saying this is something you need to be concerned about because we found a signal within your history that you need to do something about.
And there is a family history chat. There's a family history session tomorrow at 1:15.
Right. So that's going to be definitely followed through the rest of the meeting. Dr. Rahib, there was a question for you. What's going to be the impact of COVID in your modeling?
Yeah, and fortunately, I think with COVID and delayed screening, I think hopefully we're wrong, but there might be some underestimation in our model, because this year I know that there's been a lot of people who have delayed their screening and are getting later, diagnosed later. So perhaps the incidences in 2020 are going to decrease just because people were not getting their screening, but unfortunately mortality might be increasing in the next couple of years, more so than we imagined, which is unfortunate.
Right. Yeah, I think delayed diagnosis is definitely going to lead to advanced stage cancer, which we all know. So, couple of things in the chat box. Couple of stories about
Whitney. We're getting on the back end. We're getting the messaging that we need to wrap it up here quickly. So maybe time for one more question.
Yeah, well, I was just going to say in the chat room, we've had multiple episodes of people whose family history was not taken, even when they presented with young colorectal cancer. So I think this idea that you can look out into a crowd and know if someone's going to be sporadic or family, you can't tell anything. That's why everybody needs to get messaging earlier about these critical things, those warning signs that you may present out of nowhere, that critical family history that overlaps from GI to GYN to dermatology to urology to neurosurgery. So I want to just thank everyone on the panel. We went through a few little technical glitches there, but we came out okay. Lysette wasn't able to join us, and we'll be thinking about her and positive stuff. She's in a battle, and what we're going to do is close this out, but I want to thank everyone for their patience. We're going to drop it back to our guys at the booth, and we're going to soon move into our next session, which is meeting a digital artist who's going to talk to us, and we're going to have a little break from the heavy talk of cancer lifting here and get into some information about Andre Osh. And immediately following that, there'll be a networking session where your libations will be served to your specifications because you will be serving them to yourselves. Thank you so much, guys.
Thank you.
Aaron, turning it over to you.
Thank you.